So let me tell you about the QuANTUM-First study and what our objective was. We learned from the RATIFY trial that the incorporation of a FLT3 inhibitor, chemotherapy induction consolidation, and then continued thereafter in patients with FLT3-mutated AML can improve outcomes, specifically improve survival. However, there were some deficiencies in that study. The midostaurin was a first-generation drug, so not quite as potent or selective as second-generation drugs. In the study, they only included patients up to and including the age of 59, and they could have either a FLT3-ITD or a TKD mutation, and a third of them had a TKD mutation. In terms of the prognostic significance, of the FLT3-ITD is much clearer, with a higher risk of relapse and a worse survival. And so QuANTUM-First set out to see if in adults up to the age of 75 with only a FLT3-ITD mutation, if the addition of a second-generation type 2 inhibitor, Quizartinib, can improve the outcomes of those patients with FLT3-ITD mutated AML who are newly diagnosed when it's incorporated with induction consolidation in up to 144 weeks. The study completed accrual. It's now been presented, first actually at this Congress 2 years ago, and now it's been published. And the primary endpoint of the analysis of the study was reached with an improvement in overall survival in the patients who received Quizartinib compared to placebo, a hazard ratio of 0.78, indicating a 22% reduction in the risk of death. Now, that hazard ratio is identical to the hazard ratio in the RATIFY trial for the improvement in survival with midostaurin. And yet we treated patients who were older. In fact, 40% of our patients were 60 years and older in that QuANTUM-First study. And we only selected patients who had a FLT3-ITD. And in terms of every efficacy outcome, there was a higher or a better efficacy with Quizartinib in terms of overall survival, in terms of not event-free survival according to the FDA, but event-free survival according to the study, and relapse-free survival, lower incidence of cumulative incidence of relapse, longer duration of remissions, higher cumulative or composite CR rate, even though the CR rates themselves were identical between placebo and Quizartinib. There was a signal for an increased toxicity with Quizartinib. There were more early deaths with Quizartinib compared to placebo at both 30 and 60 days. Seemed to be mostly due to infection. And there's the difference between the placebo and the Quizartinib arm in terms of toxicity. The two major things are the myelosuppression, and so more febrile neutropenia, more neutropenia. And the second is QT prolongation. However, in the QuANTUM-First study, the incidence of QT prolongation was only 3% with Quizartinib and 1% with placebo for a QTc over 500 milliseconds. So that's what we know. So what are we doing or presenting now at EHA? There are two presentations. One presentation is a poster by first author is Paul Montesino from Spain here. And in that poster, we are looking at the outcomes of patients based on age, less than 60 or 60 and older. And we already had a glimpse at the data in the original manuscript of QuANTUM-First that the benefit seems to be most obvious in patients who are younger. We did not see a survival benefit that was there in the older patients. So in this poster, we try to flesh out some of that detail. Now, the benefit in the younger patients I want to focus on, because if we compare now the results of the QuANTUM-First study in patients less than 60 to the RATIFY trial that was also less than 60 but included the FLT3 TKD, the hazard ratio for survival was much lower than what was seen in the RATIFY trial. It was lower than 0.7 and approaching 30-some% reduction in the risk of death. That's in the younger patients. Now, in the older patients, there was no statistically significant difference in any efficacy outcome between placebo and quizartinib for 60 and older. So that includes survival, relapse-free survival, cumulative incidence of relapse. Having said that, in each of those, there was a trend for a numerically better survival or relapse-free survival with quizartinib than with placebo. But it did not meet statistical significance. Now, the second presentation is going to be done by Mikhail Sekares later this afternoon, where we are looking at the benefit of quizartinib as a maintenance or continuation therapy. As I said, patients could get up to 144 weeks, 36 to 28-day cycles of quizartinib at up to 60 milligrams daily versus placebo if they were in remission at the end of consolidation. The patients were not re-randomized then, so this study is not designed to show us the independent effect of quizartinib versus placebo during maintenance phase. But what we present this afternoon is that if you do a landmark analysis from the time that patients are being randomized to, continued on quizartinib or the placebo, there's an improvement in survival out during the maintenance phase as well. We then looked at the impact of that maintenance in patients who either did or did not undergo allogeneic stem cell transplant. And in the patients who did undergo allogeneic stem cell transplant first remission, in the QuANTUM-First, unlike RATIFY, they could continue quizartinib as a maintenance. However, there was no difference in overall survival or relapse-free survival between the patients who got maintenance quizartinib or placebo. And in fact, if you look at the Kaplan-Meier curves, there are a few later deaths in the quizartinib arm, not earlier on. Now, in that analysis, you have to be careful. There's clearly no obvious benefit. But these groups of patients were quite dissimilar because in patients who went to transplant after placebo and then continued placebo, there were more patients who relapsed before they could get onto the maintenance continuation of their therapy versus quizartinib, where there were fewer relapses. So the quizartinib arm was enriched for patients who were not relapsing early. Saying it differently, the placebo arm had patients who were relapsing early taken out of that comparison. So it makes the point that in this kind of trial, you really need to re-randomize at the time of maintenance after the transplant or otherwise to see a difference. In patients who did not undergo an allogeneic transplant in first remission, here we see the greatest benefit of the maintenance phase of quizartinib with a clear difference in overall survival between the quizartinib and placebo arms. Now, what I'm waiting to see is the MRD analysis, and that's being looked at now in terms of whether clearance of MRD is occurring during that maintenance phase. In terms of the age analysis, it begs the question, why did older patients not benefit as much from this intensive chemotherapy plus or minus quizartinib? Well, remember, FLT3-ITD is a late event in leukemogenesis, and many older patients, when you look at the biology of their disease, may have evolved from a myelodysplastic syndrome. And we can identify those patients by spliceosome mutations and chromatin modifying mutations, which are now considered adverse risk in the ELN 2022 risk stratification. And so that's the analysis I want to see. I want to see the molecular profile of those older patients. And my guess is that we're not going to see as much of a benefit of just targeting FLT3 because the underlying biology is such that they were not going to respond to intensive chemotherapy, and the FLT3 inhibitor doesn't do anything to target the real underlying problem in those older patients.